The following podcast is part of a certified educational activity titled AD Safe, an initiative to build understanding of ARIA and skills needed to guide treatment decisions in primary care. Access the entire activity and complete the post-test at peerview.com/SUC860. Downloadable slides and practice aids are also available.
Welcome to AD Safe, an initiative to build understanding of ARIA and skills needed to guide treatment decisions in primary care. I'm Dr. Sharon Cohen, behavioral neurologist and medical director of Toronto Memory Program. I'm delighted to have with me Scott Kaiser, and I'll turn it over to Scott to introduce himself.
Hi there, Scott Kaiser, family physician geriatrician in Los Angeles. Thanks for having me.
Thank you, Scott. So our goals today, we have several. We want to deepen your understanding of the mechanisms driving ARIA, amyloid-related imaging abnormality, in patients receiving amyloid-targeted treatments. We want to sharpen your ability to recognize clinical signs and symptoms indicative of ARIA, and refine your approach to ARIA detection and diagnosis using a structured, guideline-driven framework. We want to strengthen your skills in monitoring and managing ARIA based on established protocols. We want to optimize collaboration with interprofessional teams to enable timely ARIA detection and intervention. And finally, to elevate your approach to patient and care partner discussions by incorporating shared decision-making strategies. So let's begin with Module 1, Spotting the Signs and Recognizing ARIA in Primary Care. We are in a new era of treatment with the first disease-modifying options available for early Alzheimer's disease, and these are in the form of amyloid-targeted therapies. We have donanemab, we have lecanemab, both FDA approved and also approved in other jurisdictions. So let's take a look at these amyloid-targeted therapies that we have. Well, how do they work? They are humanized monoclonal antibodies. They target amyloid. They bind to amyloid in the brain and promote removal by microglial-mediated clearance. And they substantially lower amyloid plaque as seen on PET imaging, such that by 18 months, the majority of patients, either on lecanemab or donanemab, are amyloid negative on PET. There's also an impact on downstream AD biomarkers, such that abnormal tau and markers of neuroinflammation are improved with these treatments. In terms of impact on clinical disease, we see slowing of decline, and patients save time. They progress more slowly to the next, more disabling stage of disease. And on average, a patient may save 5 to 7 months of decline compared with placebo on these treatments over 18 months. And the longer one is treated, the more one might gain benefit. In terms of important side effects, ARIA, or amyloid-related imaging abnormality, is the key one to be aware of. And it is typically transient. It's an imaging finding seen on MRI, typically without symptoms and resolving spontaneously. However, serious and life-threatening events can rarely occur, and therefore it's necessary to understand risk factors for ARIA, how to monitor and manage ARIA, and how to individualize conversations with patients regarding ARIA. So what about ARIA? We think of ARIA as two types, ARIA-E and ARIA-H. ARIA-E stands for ARIA vasogenic edema or sulcal effusions or exudates. And ARIA-E represents proteinaceous fluid coming into the parenchymal space. We need particular MRI images to see this, flare imaging on MRI. ARIA-H represents microbleeds and superficial siderosis, two different types of ARIA-H. These are heme products seeping into the extracellular space or into the parenchymal space from the blood vessels, which have become leaky. And we need on MRI to have rapid sequences, T2 star, GRE, or SWI. It's important to recognize that ARIA-H can occur spontaneously in Alzheimer's, ARIA-E as well, but not as commonly as ARIA-H, even in the absence of any antibody treatment. So this is part of the disease, but it is enhanced in frequency with anti-amyloid treatment. We're now going to watch an animation of how ARIA develops with these antibody treatments.
Alzheimer's disease and cerebral amyloid angiopathy are both caused by the accumulation of amyloid beta aggregates, which are deposited into the brain parenchyma in AD and into cerebral blood vessel walls in cerebral amyloid angiopathy. When amyloid-targeting therapy is initiated, antibody-mediated breakdown of amyloid plaque and mobilization of parenchymal and vascular amyloid beta leads to loss of vessel wall integrity and blood-brain barrier breakdown. As a result, proteinaceous fluid and/or red blood cells can leak into the parenchyma or the leptomeningeal space, which may result in edema, also known as ARIA-E, or microhemorrhages and superficial siderosis, also known as ARIA-H. ARIA typically occurs within the first 6 months of treatment and is detected through MRI imaging. Some evidence suggests that cerebral blood vessel wall integrity improves with continued use of amyloid-targeting therapies. Therefore, the risk of ARIA usually decreases over the course of treatment.
So what are the risk factors? Some people are more prone to developing ARIA than others. Well, the APOE4 carriership is an important factor, one of the most important factors. So ARIA is more common, more likely to occur in people who have an APOE4 allele, and particularly in those who are APOE4 homozygote. That's the group that's at the highest risk. And also, other factors include the dose of amyloid-targeting therapy, the stage of treatment one is at. The majority of ARIA events due to anti-amyloid treatment occur within the first 6 months, and maybe the most severe events within the first 3 months. Also, the degree of underlying cerebral amyloid angiopathy is very important, and individuals who have on a pre-treatment MRI scan a high burden of CAA, so multiple microbleeds, superficial siderosis, and also previous macrohemorrhage may not be good candidates. They are certainly at a higher risk for ARIA with treatment with these antibodies. The extent of ischemic white matter changes can also be a risk factor for ARIA, particularly if you have severe or extensive ischemic white matter changes. And then concomitant use of anticoagulant therapy may increase the risk of ARIA. Important to remember that most cases of ARIA are asymptomatic. If we weren't doing MRI scans, we wouldn't know they were happening. When symptoms do occur, they can be transient. They are often mild to moderate symptoms and generally resolve spontaneously. Symptoms tend to occur early in the course of treatment within the first 6 months, and the common symptoms when they occur are headache, confusion, visual change, dizziness, nausea, gait disturbance. Rarely we have more serious symptoms, seizures, encephalopathy, focal neurologic deficits, stupor. So how do you approach this? The clinical evaluation is really important, and one's differential diagnosis matters a lot here because it will determine how far you go in terms of, do you need an MRI scan? Do you need to refer on to a specialist? Send the patient to emerge? What do you do? So even mild neurologic symptoms in somebody who's on an anti-amyloid monoclonal antibody need to be explored. You need to take a history. Did this symptom come on acutely? What are the characteristics? Is it very different from previous episodes of a similar symptom? And again, with headache being the commonest symptom, headache is so ubiquitous. Who of us hasn't had a headache? Is this a different headache than one's usual headache, or is this very similar? And you want to consider when in the timing of treatment with the anti-amyloid monoclonal antibody this is occurring. Is this after the first dose or within the first 6 months? And what is the APOE4 status for this patient? So that will also influence your level of risk. Differential diagnosis can include migraine or migraine with aura, ischemic stroke, which we don't want to miss, a more severe form of CAA with inflammation, and other conditions, infectious encephalitis. So very important to think for a moment that ARIA symptoms can mimic stroke. And TPA has its own risk of hemorrhage. And in the face of someone with CAA or on an anti-amyloid monoclonal antibody, TPA treatment may have a very severe, serious outcome, maybe fatal. So you really want to be able to differentiate. Is somebody having an episode of ARIA or an ischemic stroke? And the usual emerge CAT scan is not going to be sufficient. You're going to need an MRI to help sort this out. Now we're going to watch a video of a physician evaluating a patient's symptoms of headache and dizziness. Connie, it's good to see you again. Thank you for joining me on this virtual call. I understand that you've been having some headache, and I'm glad that you got in touch with me, because hopefully this is just a headache and not serious, but we do need to just make sure that we're keeping you safe. So just to recap, you're 70, you started donanemab treatment, you have mild cognitive impairment, so you caught this Alzheimer's change early on, and you've received 4 doses of donanemab. So you're on the 4th, or just past the 4th infusion. 7 days ago, I think, was the last infusion. And now you've developed a headache. Can you tell me a little bit about it? What kind of headache?
Sure. I don't usually get headaches, so this is very unusual for me. And it started like 4 days after the infusion, just throbbing, like right behind my forehead, really intense pain, like 7.5 or so out of 10. And then at the same time, I started getting dizzy and a little nauseous. And the dizziness goes away if I lay down flat, but the headache, it just seems to be there all the time. And it's just so unusual for me to have a headache that I just don't know what to do about it.
Yeah, I'm sorry. That's miserable to have a headache that doesn't let up. Let me ask you, so you don't have a history of migraines, and you say headaches are unusual for you.
No,
Okay.
no history.
Yeah. Any change in your vision or problems with your balance? Are you falling at all?
No, I haven't fallen. My balance seems off only when this headache and dizziness started. When I go to stand up, I feel I haven't fallen, but I feel like I'm off balance a little bit and a little dizzy, but I haven't fallen at all.
Okay. And no change in your medicines? You haven't started blood thinners or anything like
No,
that? Okay.
nothing.
All right. And I think that in advance of the call, we asked that you check your blood pressure at home and your temperature. Were you able to do that?
I was. My blood pressure was 130/80, and my temperature was 99.
Great. Okay. So, because so many different things can cause a headache, an infection can cause a headache, that your temperature is pretty normal, blood pressure isn't too low or too high, it's actually excellent. So that's very reassuring. Um, any stiffness in your neck?
No.
Okay,
No.
that's good. That's good. Can I ask you to do a few things? I realize this is a video call, so it's not quite the same as me examining you in the office, but I'm looking at you. Your face looks very symmetrical. Can you just show me your teeth like this? Perfect. Good. I don't see any drooping or weakness on one side of the face. Can you shut your eyes tight? Close them tight. Perfect. Open them. Good. Now I want you to look up at the ceiling. Good. Down at the floor. Good. Keep your head still and look to the left now. And to the right. Okay. So eye movements look normal. And now I want you to scoot back a little bit so I can see you raise your arms up if you can. Terrific. That's good. Turn your palms to the ceiling. Keep them up there and close your eyes. Excellent. Okay, you could let them go. And now I want you to do this, quick as you can. Good. And the other hand? You're faster with that one. Is there a reason?
Oh, I have a trigger finger. I'm going to have surgery in another 2 weeks.
Okay.
So fingers
Okay.
are
That was not a fair test. Okay. What about just drumming on your hand here? And just looking at how rhythmic and regular things are. And then switch hands. It may feel a little bit awkward with the non-dominant hand. Very good. Okay. All right. So everything in this quick and dirty, assessment looks fine. But because you've just finished a 4th infusion of donanemab, and there is a possibility of ARIA, particularly in the first 6 months of being on one of these anti-amyloid drugs, I think we should, to be cautious, get an MRI scan, because you won't have another scheduled MRI for another few months. And I'd rather we not wait and guess. And depending what the MRI shows, then we'll decide whether we hold the next dose or whether we can continue on. Meanwhile, Tylenol for your headache would be a good idea if you haven't taken it. And I hope that it passes pretty quickly. Any questions or concerns?
No, my husband, I told him we'd probably have to go, so he's ready to take me whenever we can get that appointment for the MRI.
Okay, terrific. So we will get that organized at my end and then be back in touch quickly.
Okay. Thank you, Dr. Cohen.
You're welcome. Take care, Connie. So we see from this video that it's important to explore symptoms, especially any symptoms, but if they're non-specific, we need to dig a bit deeper. What would be your approach to someone with a headache who's on an anti-amyloid monoclonal antibody?
Well, yeah, I mean, that was a very helpful video, and I think we're gonna get more into that as we go into this, particularly from the primary care perspective, because it's challenging, and this is why so much of the situation, the background, the context is important. You really need a thorough history, and this is a good approach.
Good. Yeah. And I think overarching, we don't want to minimize, we don't want to overdiagnose, but we also don't want to miss something that could become more serious. So we need to be diligent. I'm now going to turn over module 2 to my colleague, Scott.
So continuing with this theme of ARIA management in the primary care setting, let's talk about kind of recommendations for the routine MRI monitoring during treatment with anti-amyloid antibodies. So this is all very clearly protocolized, but as is discussed, it's really essential that this schedule is followed and that there are appropriate resources for the interpretation of these scans. There's a scoring system, and this needs to be followed. So as you can see here, I'm not going to read through all of the details, but with lecanemab or donanemab, you have this clear schedule of when to have the MRIs. Now, note, as you look at the bottom of the slide here, that this changes if there are symptoms, right? And this is what we've been talking about, is that if you have concerning symptoms and warranting further investigation, you go ahead and get another MRI, because we want to be able to detect this. So in terms of those symptoms that would be consistent with ARIA that would trigger getting an additional MRI, right? There would be acute or subacute onset of new neurologic symptoms. So headache, that's a tougher one, as we said. It takes a lot of additional clinical judgment there, as they're so common. But again, new onset, considering alignment with the treatment course and everything, this list of symptoms that Dr. Cohen already went through, this is just something where we really want to be on alert, and then have a low threshold for having an additional MRI to evaluate for ARIA. And then, of course, the symptom severity is going to be a key factor as well. And again, obviously, as symptoms are more severe, just really want to sort of proceed immediately to further evaluation, MRI, and specialty involvement. Of course, people, there's a broad differential diagnosis, and we should still be thinking about things like stroke or infection. But the point is, again, severe symptoms absolutely necessitate prompt imaging and referral, and may even require hospitalization with specialized management. Again, rare cases, as Dr. Cohen pointed out. The majority of these are even asymptomatic, but there are, cases where people need intensive care, et cetera. So, another thing to think about is, are these resources in place in your setting as you're proceeding with treatment? And then, as I noted, there are classification criteria for the changes that would be seen on neuroimaging. Again, you don't need to commit this to memory, but it's important to understand that there's this mutually agreed upon set of criteria, and that your neuroradiologist should be following this, so that, again, in terms of not just triggering additional assessment, but in terms of when you discontinue treatment or continue treatment, these criteria on what's seen on the imaging are built into the protocol of how you manage ongoing treatment. So very important to make sure that this is being followed. And then as I was starting to allude to, there's a management algorithm that takes into consideration clinical factors, imaging factors. So as you can see here, you have your baseline MRI, which is required before treatment, then routine MRIs that may be conducted because of symptoms of ARIA. If ARIA-E or ARIA-H are detected, you then differentiate whether you're talking about a symptomatic or asymptomatic case. And then, as you can see, you proceed from there to determine how you're going to proceed with, again, the next thing being looking at the scoring on the neuroimaging. So again, you're going to stop the treatment if there's any macro hemorrhage, if there's greater than one area of superficial siderosis, if there are over 10 micro hemorrhages that have emerged since treatment initiation. Again, that's why you have that baseline, so you can compare greater than 2 episodes of ARIA, severe symptoms of ARIA, or patient requiring treatment with an anticoagulant. In terms of the management of symptomatic cases of ARIA, as was noted, most of these cases will resolve on their own without the need for really any treatment intervention. But serious cases may require treatment, including hospitalization and ICU admission. Now, in the outpatient setting, management of ARIA involves steroid taper, potentially anticonvulsive therapy for seizure management or prophylaxis after hospitalization for severe symptoms, following up, of course, to ensure that the symptoms are improving, educating patients regarding risks and benefits of continuing treatment with ATTs. We're going to get into shared decision making, and it's really critical at every step along this pathway. And coordinating, of course, with specialists, with neurology, with imaging centers and other specialists as needed. And then ensuring that patients and care partners understand the warning signs that require urgent reevaluation. So low threshold for detection of any recurrent cases. And in terms of effective communication, right? So a lot of this, obviously, it's not likely to be occurring in the primary care setting. So making sure that all of the, maybe presenting in primary care, but the management requires a broader team. So it's really important to have direct information exchange. Sometimes it can help leverage technology to achieve better team communication. And as we're going to get into in a moment here, you really do want to be specific, right? You need to be specific in specifying the clinical concerns, and not just ordering an MRI, just MRI brain. You need to really make sure that the radiologist knows that you're concerned about ARIA, and that everybody's sort of on the same page. And so that information should be communicated to the radiologist regarding the therapy that the patient's receiving, the dose, duration, when the last dose was, and as we'll get into, risk factors for ARIA-2, and whether they've had previous episodes, because as you saw, whether it's a recurrent episode is important in terms of the overall management. So going a little bit deeper here, I mean, I think this classic kind of situation, background assessment recommendation framework is very helpful in terms of thinking about having good, clear communication. This is about communicating that critical information in a concise, clear way between different members of the healthcare team. So helpful to talk about what's going on with the patient, right? So this patient's come into my primary care clinic and they've got a persistent headache and some occasional dizziness for the past few days. That's what's going on. The background is that this patient just started donanemab 4 months ago and has been tolerating it well until now. But her last infusion was a week ago, and she doesn't have any history of headache. This is really new. And by the way, this is somebody who carries a copy of the E4 allele, and that certainly elevates the risk for ARIA. So we're keeping that in mind. And our assessment is that the patient's stable with stable vital signs and an unremarkable neurologic exam, but this headache came on suddenly. It's severe in intensity. It's pressure-like. And again, it's new. It's definitely different. And so you're reporting your concern that this could be ARIA, particularly in light of this recent donanemab infusion. So now you're being clear in terms of what you're requesting. You're ordering an urgent MRI to assess for ARIA, and you're looking forward to guidance on next steps. So that's very thorough and making sure that everybody's on the same page. So in terms of resuming treatment after the resolution of ARIA, again, this is going to likely involve specialty direction, if not certainly input, but good to be aware of this in the primary care setting in terms of understanding that, what happens next. So when patients and families are coming to you wondering, okay, what's going to happen next? And the treatment can be reconsidered once the symptoms resolve and there's resolution on MRI or of the ARIA-E or stabilization of the ARIA-H. So again, this really becomes something where you have to go over the risks and benefits, opens the door to shared decision-making, and again, taking all of these factors in terms of severity, comorbidities, baseline risk, concurrent medications, all taken into account. And so that's why, these things that are not all black and white, there's a lot of gray area, necessitate really top level shared decision making. So this is just so critical in this area in terms of whether these treatments are the right fit for folks, and then in terms of understanding the risk of ARIA, and then in terms of understanding how to proceed with treatment should ARIA cases occur. So again, a helpful framework, thinking about establishing the goals and expectations, being clear about the risks and the alternatives, and being clear in presenting caveats in terms of the fact that there are certain things that we know from the research, and there's many things that we're still learning in these novel therapies. So, again, very, very important. And then, of course, we've got to talk about the risks. We talked about a variety of risks, but ARIA is really the most novel and concerning risk here that we need to explain. And because it's a lot of new information, it's new to clinicians. Certainly, new to patients and families, this is something that we just need to be able to communicate in a understandable way for the lay person. And then, as we've pointed out here, we can talk about, what might put them at greater risk for ARIA, so that could help inform their decision, and then help them understand what many of these cases, the majority are asymptomatic, but understand what the symptoms might be, including differentiating these more mild symptoms that are likely transient, and then the possibility of more severe symptoms. And again, reminding people to report those things urgently. Same thing in terms of, as we've been discussing, once somebody is diagnosed with ARIA, there is a lot of shared decision-making that needs to come into this in terms of where we're to go. We can go over the recommended protocols, but at each point of the way, there are clinical judgments and things where we need to align this with what the patient's goals, values, expectations might be. And I'm just wondering your thoughts in terms of how to effectively integrate a patient-centered communication approach into your discussions about anti-amyloid therapy and ARIA.
Sure. Thank you. Yeah, I agree that being patient-centered is key. So I like to know something about the patient in front of me and the care partner. And what are their values? Are they feeling that slowing down their disease is worthwhile, saving time, and being able to continue to be relatively independent and living in their own home? And I think that if you communicate that, many, many patients say yes. In a disease where, I'm going to lose abilities, I want more time at the earlier stage. Some patients say, no, I want to improve. If I can't get better, then this isn't the treatment for me. And we have to be respectful of that. So, for some people, it's more about improving symptoms. That's not what this type of therapy is going to do. And then in terms of ARIA risk, is the risk that we're describing acceptable to the patient? Are they willing to comply with the MRI monitoring and the vigilance required? Most patients are. For some, that just doesn't fit into their lifestyle or their desire. So everybody's a little bit different in terms of how risk averse they are. So providing clear information is important, what we know about ARIA, but also listening to what the patient has to say or the family about how they feel about that, how willing they are to engage in this therapy.
Yeah, good old-fashioned understanding of what matters most to the patient and care partner's family, right? With this disease in particular, often there's the identified patient and then the critical importance of so many others in the extended family friend unit. So we have another case here in a video, and here the physician engages in a collaborative dialogue with this patient about ATTs. And we're exploring ARIA risks and exploring benefits while incorporating the patient's values, preferences, and concerns into the discussion. So let's take a look.
We're not yet able to cure Alzheimer's, but we are able to slow it down. And for people like you who have caught the disease early, at the mild cognitive impairment stage, there's so many things you're still able to do and enjoy. We feel as a scientific community, this is worthwhile, but what about you? What would your goals be?
I think I told you my mother died at 78 of Alzheimer's. And so I kind of know what the future looks like, and I'm willing to try anything that will delay that progression. So that's why I'm really motivated, because I know I can't reverse the disease, but I'd like to do anything I can to slow it down.
So I think with that, actually, we're going to wrap it up. Here are some of our take-home messages. Number one, providers should engage patients and care partners in discussions about ATT risks and benefits, both before initiating therapy and after a possible ARIA diagnosis. Most cases of ARIA are transient and asymptomatic, and they typically occur early in the course of treatment. ARIA is more likely to occur in APOE4 carriers and is most likely to be symptomatic and severe in those who are homozygous for the E4. We want to maintain a high index of suspicion for ARIA in patients receiving ATTs, and monitoring protocols are central to ARIA management and include both scheduled MRIs and unscheduled MRIs that may be triggered by symptom onset. Management decisions for ARIA depend on symptom severity and radiographic findings. And finally, effective management of ARIA requires clear communication and collaboration between primary care providers, neurologists, and radiologists, etc. And with that, appreciate having had the opportunity to do this with you, Dr. Cohen. Very informative. And thank you.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/SUC860.